Hey everyone, welcome to another Facebook Live here at NewSouth NeuroSpine. We are in our surgery division again today, and we have neurosurgeon Dr. Jack Moriarty with us. He's going to be talking about when you truly need spine surgery. Also, we have a VC gift card, 2 of them, that we're going to be giving away to people who ask questions and make comments. So, without further ado, here is Dr. Jack Moriarty.
Hello, everyone. Because this is a virtual setting, I'm going to do away with this, which will be a huge relief. But rest assured that if you do come to the office to NewSouth NeuroSpine, we are screening folks at the door, making sure that everyone has masks on, providing those if a patient doesn't have a mask but needs to be seen. We're also checking temps, making sure you don't have any concerning history of cough or fever. So rest assured we're being safe, but I'm gonna set this aside happily for the moment so that I don't have to be in it while we chat. A few people have asked just some background information to start, so I thought I would tell people a bit about myself and how I ended up here. That's probably the question I get the most. So I grew up in Los Angeles, California, actually a town called Calabasas that used to be a small out-of-the-way town and was a really great place to grow up, but like much of Los Angeles has been really overdeveloped. And so it's now a bit more crowded, a bit more like the rest of Los Angeles. But I grew up in Calabasas, California, and then went north of there up to Stanford University for college and for medical school. And then in 1995 finished medical school and went to Baltimore, Maryland, to Johns Hopkins Hospital. And that's, I think, when the seed was planted that would land me here in Mississippi, because during my time at Hopkins, I met John Davis, who is a Jackson native, actually a Rankin County native. And John, in 2001, called me and asked if I was thinking of looking in Mississippi when I finished my training at Hopkins, which was going to be completed in 2002. And I recall telling John that I was not sure I could find Mississippi on a map, but that I would happily come down and look at a job with him. And so he took that the right way. He didn't hold it against me. And so my wife and I came down. We had 1 child at the time. And we just really more and more loved the idea of working and living in Jackson and raising our family here. And so in 2002, we moved here with 1 child and now have 3, and we have been here ever since. So it has been a huge blessing for us to be here. Let me look and see if I can see what some of the questions are. There's a bunch of hellos, which are not terribly
Why don't you start with
not terribly good for discussion topics, but hello to everyone. One of the topics that you'd mentioned, that Lanier had mentioned at the beginning, was discussing how it is we decide someone needs surgery. And I think that's an interesting thing to discuss, and obviously very relevant for patients that we see. And I think at first when people hear this discussion, it's a little bit counterintuitive. So I'll go through this, but bear with me if at first it sounds a little odd. So I think the decision about whether or not someone needs surgery should be divided into 2 distinct parts. And this is the part that sounds a little bit odd. Is the first part, in my opinion, is an entirely surgeon-based decision. And I know that sounds completely wrong and it doesn't sound patient-centered, but I think it's actually the safest way to make this decision. So for me, the 2 parts of the decision are: first, does the patient have a structural abnormality on their films that matches their symptoms, that can be fixed with surgery with a reasonable risk-benefit ratio, meaning not too much risk, but a good amount of potential benefit. And the reason I think that has to be the first question that is asked is because if that's not true, if say the patient has an entirely normal lumbar MRI, then I don't think the next part should sway you to consider surgery. So the first part is there a structural problem there to fix? Because the vast majority of spine surgery and neurosurgery is treating a structural problem. Now, that's not true for all the surgeries that are done, but the vast majority, and certainly the things that I do, are treating structural problems. So the first question is there something on the scan that can be fixed and that should be fixed? The second question is all the patient factors. How much is it bothering the patient? What other methods of treatment have they tried? Have they had an adequate trial of time? Usually some form of steroid therapy, physical therapy, epidural steroid injections, and things like that. But the first part is there a structural problem that should and can be fixed with a reasonable amount of risk and benefit? If that's not true, then surgery is not even an option. And that's something that surgeons need to remember, is that if there's not a structural problem there, then surgery does not have a chance of helping, regardless of how bad the patient's symptoms are, regardless of how many other treatment modalities they have tried. There are some folks that were just not able to get better with surgery or non-surgical care, and in those patients, it's not reasonable, in my opinion, to just try surgery because the patient's tried everything else. I think that's generally a setup for failure, and exposes the patient to the risk of surgery without potential benefit. And let me see, Linear, can you read some of these, or I'm going to have to don these and see if I can. So
you have some people, Linda Peterson, one of your patients,
yes,
watching.
So we have a number of people saying hello.
Why don't you?
Someone had said Dr. Davis is great too, which
Angela McCall.
Yeah, no, I would agree with that. He's led me here. He was also one of the people who convinced me to go to Hopkins for residency, so I have followed him all over the country.
Do you want to talk about the MRI behind you?
We could do that. So I don't know that this will work. I don't know if you can see. I'll move these for a sec. I don't know if that's visible, but we can, hopefully people can respond. But this is basically on this side of the screen here, you can see a lumbar MRI. This is the front of the patient here. This is the back of the patient, and I'm hoping that you can see this. The chat portion of the talk is covering the screen, but I'm going to assume that you can see this. This is basically looking at someone's low back. Here's the small of the back here, and here's the front of the person. The head is up here towards the top of the screen. Feet are down here. And these are the individual bones of the low back, and then in between the bones are the shock absorbers or the discs. So this is one of the MRIs that I would look at, and in my opinion, and this is something somewhat controversial within neurosurgery, but I would say in my opinion and that of my partners, this is not an MRI for which surgery is appropriate. Although I would say that this type of MRI and patients with this type of MRI are recommended for surgery regularly. And that's a sad but true statement that, in my opinion, a lot of surgery is being done that does not need to be done. It is very uncommon to actually need surgery to treat complaints related to the neck and the low back. But so in this MRI, if this patient complained of back pain, and I can show this MRI without worry about confidentiality because it's actually my MRI from about 4 years ago. But if you look at this MRI, you can notice this one disc is a little darker than the other discs. That was true of my back 20 years ago when I was in my 30s when I had significant back pain. At that time, I was told that the reason my back was hurting was because that disc, that bottom disc that we would call L5S1, I was told in my 30s that my back was hurting because that disc was worn out and that surgery could be an option to fix that. Well, as a neurosurgery resident at the time, I knew just enough to know that that was probably not a treatment I wanted to pursue, and so I avoided it, tried to be reasonably active and work on core strength, and thankfully my back pain went away. Well, now fast forward to when this MRI was done, and that disc looks a little more worn out, although still not significant, looks a little more worn out, and my back doesn't hurt hardly ever. It bothers me now and then, but much less significant pain than I had 20 years ago. And yet that disc that was the culprit, in theory, 20 years ago, is now more worn out, but I don't hurt. And I tell patients that story just to underscore the fact that we don't understand back pain terribly well. And that, to me, is one of the main reasons to be very hesitant to have surgery when your primary complaint is pain in the back. I think surgery for pain shooting down your leg or pain going down your arm, our diagnosis is much clearer and our success is much higher. But pain directed at treating back, surgery directed at treating back pain is fraught with a high degree of failure. And I think one of the main reasons is because of our poor diagnostic accuracy in those cases.
One question, talk about the difference between the way y'all used to do back surgery 20 years ago and minimally invasive surgery now.
So that's an interesting topic. So there's a push in surgery in general, and particularly in spine surgery, to move towards minimally invasive approaches. And I think I have sort of two main thoughts about this. Is first, the most minimally invasive surgery is no surgery. And that is an option that you need to consider, is how can I get around this without having surgery? So can I work more on core strength? Can I work on weight loss? Can I stop smoking? Things like that. I think it's important first to remember that in spite of all the craze about minimally invasive surgery and all the ads you see on TV where people go home the same day with a Band-Aid, which is accurate, we need to remember that the most minimally invasive surgery is no surgery at all. Or the least invasive surgery would be no surgery at all. So that's an option to consider. If you do need surgery, if you're appropriate for surgery, then there are a number of minimally invasive approaches that have become more and more common over the last really 5 to 10 years, 10 to 15 years. And most of them, well, I would say they divide into two groups. Some of them are doing the same surgery through an approach that does not disturb the muscles around the back as much, and that's the most common minimally invasive procedure done, which is a typical discectomy where pressure, if we go look at this MRI, if this disc were pushing backwards on a nerve, we could go into the spine and take pressure off that nerve. Well, the means by which we get there has improved over the last 10 to 20 years. In terms of the retractors that we're able to use and the approach we use in terms of the muscle of the low back. So now we have minimally invasive retractor systems that allow us to get in and out of the back and leave a smaller footprint on the patient's body. So that's one way in which minimally invasive approaches are used, is to do the same procedure, but to do it in a less invasive or less tissue damaging way. The other way is that there are just unique procedures now that did not exist 5 or 10 years ago. And certainly some of my junior partners employ techniques like that, like robotic guided screw placement, relying, almost entirely on imaging guidance, working through small ports to place instrumentation into the spine. So techniques like that are similar to what we did in the past, but I think a more dramatic departure from the conventional approach. And the goal is really to achieve the same structural results, but leave a smaller footprint on the body. I think that is another, we talked about reasons why surgery for back pain as the primary symptom has a lower success. One is that we don't understand back pain as well. And I always use myself as an example. I was told at 30 that I had back pain because I had a degenerated disc, and now I'm just over 50. That disc is understandably more degenerated, and my back hardly ever hurts. So we clearly don't thoroughly understand back pain. So that's one problem with surgery directed at that. The other problem is that oftentimes surgery that is directed at treating low back pain leaves a larger footprint on your body, and the surgery itself can generate symptoms. And that's one thing that the minimally invasive techniques that my partners employ in placing instrumentation are a huge benefit to patients, and allowing them to be up and around sooner with lower pain medication requirements after surgery. Some of those surgeries now that when I was a resident at Johns Hopkins would have required a minimum of a 3, 4, 5-day hospital stay, I now have junior partners who can do those procedures in an ambulatory surgery center, and the patient's able to go home comfortably the same day or the next day. And so that's a huge improvement. We still have the problem of understanding the source of back pain, but in the correct subset of patients, those surgeries can be a significant benefit.
Tanya Frazier is asking, are there any recommended ways to strengthen the muscles affected by cervical spine stenosis?
So the question was, are there any ways to effectively strengthen the muscles of the neck if the neck's affected by cervical stenosis? And so there's multiple parts to that answer. First, I think it'd be worth going over what is stenosis. So stenosis is simply narrowing of a tube. So if you think of any cylindrical structure in your body, if that structure becomes narrowed, we call that stenosis. So in my world, that's most often the spinal canal, in the neck, in the mid-back or thoracic spine, or in the low back. And so we see cervical stenosis, thoracic stenosis, or lumbar stenosis as some of the most common things we treat. So that's what stenosis is narrowing of the spine. And then the next question was strengthening the muscles and its relation to helping with the symptoms of stenosis. And in general, for me, I would think of strengthening the muscles as a bigger help for mechanical back pain or mechanical neck pain. Technically, if your stenosis is bad enough, then I'm not sure strengthening the muscles around your spine will be an adequate treatment for that. And the way to know that is to have an MRI and to have it looked at by a specialist. But from a symptoms point of view, the way you can know that is thinking about, are you more bothered by neck pain and back pain, or are you more bothered by symptoms going into your extremities, into your arms or legs? Significant stenosis, which is again narrowing of the canal, say in the lumbar spine. So significant stenosis or narrowing of the lumbar spinal canal will manifest itself primarily as pain that goes into the legs, into the buttocks, into the thighs, and into the calves when you're up and walking around. And if stenosis is your main problem, that will be your main complaint. You will also have some degree of back pain, but your main complaint will be in your buttocks and your thighs and your legs. So if that's your main complaint, then I do think an evaluation for stenosis with an MRI and seeing a specialist is a good idea. And I'm not sure strengthening the muscles of the spine will help with that problem. And that would be true also for stenosis in the neck. I think that's something that should be looked at if you're having symptoms going into your arms, trouble with using your hands, numbness radiating down your arms. I'm not sure that's a problem I would recommend treating primarily with strengthening the muscles of the spine, although I think it's a great idea for all of us. I don't think that's the primary means of treatment. I think the strengthening the muscles of the spine for the neck or the low back, I would say, are the main treatment if you have mechanical neck or back pain. And by mechanical, I mean pain that gets worse with activity. So when you overdo it or are active or do your normal daily living activities or your work activities, if your back or neck ache, then those are the times I would think about strengthening the muscles around that complex of joints, which is the spine.
Talk about the different, if you don't need surgery, what we offer here, the non-surgical options.
So someone asked about what are the non-surgical options, and I think there are a number of non-surgical options. I would stress though that some of the most effective ones, and this is good news or bad news depending on your perspective, some of the most effective non-surgical options are entirely up to the patient and don't require a large spine center or fancy physical therapy or X-ray guided epidural steroid injections. They simply require basic things like weight control, exercise, working on core strengthening, stopping smoking, stopping the use of cigarettes. Basic health measures can have a huge impact on how you feel in general, but in particular in how your back and neck feel. So, and that's good news or bad news depending on your perspective. I know everyone wishes there were some quick pill or shot that we could give them to rid them of pain, but the reality is a lot of burden of feeling better and getting better is on the patient. And I've learned that myself, that when I don't work on core strength, my back hurts when I'm in the operating room. If I do diligently do my core exercises, my back doesn't hurt. And even knowing that and being a spine surgeon, I still neglect to do the exercises every now and then because we all have trouble sticking to any program. But so those are the first non-surgical measures, and those don't require a fancy spine center or the help of an expert. Beyond that, if those measures are not successful and you have significant enough pain and a structural problem that we're trying to manage non-surgically, I think the key parts of non-surgical treatment are physical medicine and rehabilitation, which is one of our divisions here. And that is basically coordinating all of the non-surgical measures that are, from a patient's perspective, sort of related to physical therapy or treatment modalities like physical therapy. So that's one arm of our non-surgical treatment, is physical medicine and rehabilitation. And then another arm would be interventional pain management. And that's another division we have here. And those are the treatment measures that involve things like epidural steroid injections and facet blocks and SI joint injections, basically X-ray guided injections of usually steroid medication into the areas of the spine that we think are causing symptoms. And often those two elements are used together. So often an epidural steroid injection will ease the pain enough that the patient can more completely participate in physical therapy. So it's not an either or proposition. It's often the two of them used together, and that's part of what prompted us to create NewSouth NeuroSpine, is so that we could better coordinate the different elements of care on behalf of our patients.
You mentioned earlier that about smoking and having surgery. Why is it? What's the difference? Like,
Well, I think there are a number of pieces of evidence, and I'm not sure that everyone out there can hear all the questions, so I'll repeat them. There was a question about why is smoking related? And smokers ask me this all the time, sometimes in a very pointed adversarial way. But why do I keep blaming smoking for back pain? And I don't know that I have a molecular understanding, or even that we do have a molecular understanding of it, but there are multiple lines of evidence pointing to the fact that smokers have a higher incidence of back pain, have more difficulty recovering from an injury in terms of back and neck pain, and have more difficulty recovering and healing properly from surgery. And I think the simple way I think of it is that our body is constantly going through a process of injury and healing. And when you're 10 years old, the healing more than keeps up with the injury part. So a 10-year-old can fall 5 feet out of a tree and get up, and the next morning they're not sore. They feel fine. A 52-year-old falls 5 feet out of a tree, and the next morning I know it, because I'm not able to repair. One, the tissues don't respond to the range of motion as well because they're not as flexible. And two, we don't repair things as quickly. And in my opinion, cigarettes and the components of tobacco products sort of tip the balance of injury and repair to where the repair part is a little bit slowed down and the injury part isn't. And there's probably an additional injury from tobacco products. And so I think in the back, you have a higher chance of back pain. You don't heal as well from surgery. You don't heal as well from an injury. So it is an important thing. Core strength is an important thing, and body weight are important things. And patients often don't like to hear that because it puts the ball in their court. But in a lot of ways, the ball is in, and I'm a patient too. I've been through, our physical medicine division. I've been through therapy, have avoided surgery to this point, but I get it too. I would love to find some quick fix where I don't need to do something to maintain my core strength and avoid back pain. But the reality is that the burden is on the patient to some degree.
We had another question earlier from Tana. She wants to know if an inversion table would be helpful for lower back pain.
So we have a question about inversion tables. And for those of you that don't know what those are things where you hook your feet. You can see them at the back of Dick's Sporting Goods. You hook your feet and then gradually tilt it to a different angle and allow your head and your body to hang kind of from your feet. That's generally a form of traction, and I am a huge fan of traction for neck and low back problems, as long as it's something the patient can tolerate. So with an inversion table, I think it is a great treatment option for people with back pain. It kind of unloads the back and sort of reverses the forces that are usually working on the back through gravity. So I think it's a very helpful thing. I think one of the things that limits the success of an inversion table for patients with low back pain is that some people can't tolerate being inverted. Some people develop a real headache and are uncomfortable like that. Similarly, I think in the neck it's easier to do. You can do it with a traction collar, but for me, it's very, very uncommon for me to recommend surgery on someone's neck for a pinched nerve without them having tried some form of cervical traction, because I think it's a very simple and successful thing to do. But again, it should make you feel better while you're in it. So I would not do traction or an inversion table. I would not think of it the way we think of maybe an antibiotic, where I know it's going to upset my stomach and it doesn't taste that good and it's kind of a pain to take, but it's going to make me feel better in the end. You shouldn't think of traction that way. So traction should feel better while you're doing it. You shouldn't treat it as, gosh, this is killing me while I'm doing it, but I know it's good for me. That if the traction's hurting while you're doing it, in general, I would say don't do it. It's probably going to do more harm than good in terms of your comfort level.
Will wants to know if you could touch on like radicular pain during pregnancy, and if there's anything.
So we have a question about radicular pain during pregnancy. So let me unpack that. So radicular pain, the term radicular means related to the nerve root. And so if you imagine your spine and the nerves, here, I'm going to go back to this picture if you can still see it. So running along here, if we look at the low back, here's the spinal cord is ending here, right there. The spinal cord ends there. That's something most people don't realize, that in the lumbar spine, in the low back, there's very seldom any involvement of the spinal cord because it ends at the very top of the low back. So the spinal cord ends here, and then these nerves come down. Well, these nerves, just as they leave the spinal canal for a small segment of their life, they are called a nerve root, and they're given a number based on where they are, a letter and a number based on where they are in the spine. So it's this beautiful anatomy from the cervical to the thoracic to the lumbar to the sacral spine, where the nerves are each given a letter and a number. Those are the nerve roots. And when we want to talk about a problem related to the nerve roots, we use the term radicular. So that's what radicular pain is pain that we're assuming is from a nerve root. So now for when that occurs in the setting of pregnancy, and part of me cringes a bit because as a surgeon, there's very little we can do for radicular pain in pregnancy. It is, and I say very little we can do as surgeons because obviously in general, surgery is just not an option until after delivery. And thankfully, after delivery, it's often not needed because of all the changes that have gone on with delivery. The symptoms are often much better after that. But so radicular pain in pregnancy is not uncommon, largely because of the body changes and the activity level changes and just the added stress on the body. It's not uncommon for a disc that may have not bothered someone or not pinching a nerve prior to being pregnant now is bothering the mom when she's pregnant. And so that can happen. It's hardly ever a significant threat to long-term health or well-being. It's not something during pregnancy that we would generally recommend surgery for, except in very, very rare circumstances. So in pregnancy, generally we are limited to things like Tylenol and a trial of a steroid dose pack or a Medrol dose pack. And that's usually that, and then rest and waiting until the baby is delivered, and then reevaluating mom after that. But oftentimes the symptoms go away after delivery.
Have you ever done
Well, so there's a question about just operating on pregnant patients, and in general, we would try very hard not to do it. Off the top of my head, I cannot think of a time I have ever had to do it. And again, that's because most of the things I'm treating are within the spectrum of neurosurgery, much more towards the elective side of the spectrum. So we're not doing as many emergent procedures. So there are times where you would need to operate on someone who's pregnant, and then that's just something that has to be done. But in my practice, that is very uncommon. We would try not to expose the baby to general anesthesia and things like that. And so it would be something we would try to avoid. There's also issues with X-ray. I did have a case of a friend's sister, actually a friend of mine who we trained together at Hopkins and is now a peds neurosurgeon. His sister wanted to come from Philadelphia, Pennsylvania to Mississippi so that I could do surgery on her. And it was during her pregnancy. She had a severe radiculopathy. So she had severe radicular pain in her leg, could not stand it, obviously limited on the amount of pain medication she could take. And so thankfully she got better. And that was ended up not being a huge issue. But there are issues with the X-ray to try to figure out how to localize where we are in surgery. We often shoot 1, 2, 3 X-rays during surgery, and that's also not something you would like to do while someone's pregnant. So in general, it is often Tylenol and a Medrol dose pack, and then waiting and trying to suffer through it. But thankfully it does get better. So not all hope is lost.
What procedure do you do the most of, and which one has the best outcome?
So the question was, what procedure do we do? What procedure do I do the most of, and which one has the best outcome? And I would say that my answer to that would be true for my practice, but would be also true probably for any general neurosurgeon practicing in the United States. So in general, the people that we do that have the highest success are the ones whose primary symptoms are symptoms radiating into their extremity. So either into the upper extremity, into the arm and forearm and shoulder, or into the lower extremity, into the hip and buttock and thigh and leg. Those are the people for whom we do the best. And again, it's for the two reasons that I mentioned earlier, related to why patients whose primary complaint is back pain are the patients that we struggle the most with. And the reason is because if you have pain radiating into your, say, lower limb, so it goes into if someone comes into my office and says, I have pain shooting into my buttock, into the back of my thigh, and into my calf, and then I examine them, and they have certain reflexes that are decreased, like the reflex that their heel is decreased, and they're a little weak in pushing their foot down. And then I go look at their MRI, and as expected, they have an L5-S1 disc herniation. So that would be this disc. Very common problem. The diagnostic accuracy in a patient like that is incredibly high. And the most important thing that determines our success in surgery is diagnostic accuracy. That seems self-evident, but it's missed. That fact is missed by a lot of people. That the main thing we need to do, the main benefit we can provide a patient is figure out what's wrong. It's not, the main thing is not the application of some new fancy technology. The main thing is to listen to the patient, examine the patient, and then study their films and put those three things together to arrive at a clear diagnosis. And so it's not surprising that the most successful patients in my practice and in general neurosurgery across the country are the patients whose primary complaint is either radiating into their pain radiating into the upper extremity or pain radiating into the lower extremity, and an MRI scan that clearly shows a pinched nerve that matches that distribution. So those people are, that's some of the most common things we do, and also some of the most successful, because one, we know the diagnosis very well with high accuracy, and two, the surgeries to treat that set of problems are not as invasive or as large as surgeries that are geared to treating general mechanical back pain. So remember, the problem with surgery for back pain is two things. We struggle with the diagnosis, and the surgeries tend to be larger, so they leave a bigger footprint on your body. And the opposite is true when you have pain just shooting into your leg. Oftentimes, not always, but oftentimes, those surgeries are based on a firmer diagnosis, a clearer diagnosis, and they're smaller procedures that don't leave as big a footprint on your body.
We had a question from Haley, and we kind of touched on this earlier, but she wanted to know about minimally invasive surgery.
Yes.
Can you name a couple of them?
I can even read that one without my glasses. Yes. So Haley has asked, do you perform minimally invasive surgery? So yes, I would say the most common, far and away the most common lumbar spine or low back surgery I perform is a minimally invasive lumbar discectomy, which is basically, if we refer again to my MRI, it's basically inserting a minimally invasive tube through the muscle here and working through that tubular retractor to take pressure off of a nerve. It's a procedure that is usually done through an incision that is anywhere from, for me, probably 18 to 22 millimeters would be the common length for those incisions. And to put that in context, an inch is about 25.5 millimeters. So somewhere less than an inch, 2/3, 3/4 of an inch. And that surgery usually takes about 30 to 45 minutes. And those patients can go home the same day. So that would be called a minimally invasive microlumbar discectomy. Patients often call it the Band-Aid procedure. It is occasionally called the laser procedure after a now defunct spine center that sprung up, or spine centers that sprung up around the country, but it was never entirely clear how the laser was being used for those procedures. So I'm not sure it adds much, but patients will often ask, is it the laser procedure? And I think in terms of the retractor, it's a very similar operation. So that's one minimally invasive procedure, and that's the most common one I do. The other procedures that some of my partners do, particularly two of my junior partners, Matt Van Lanningham and Eric Amundsen, do very elegant procedures with placement of instrumentation through minimally invasive techniques. So using robotic guidance and x-ray guidance and imaging guidance in general to place screws into the lumbar spine to treat much bigger structural problems, but to still do it in a very minimally invasive way. So that's another procedure that is probably the second most common minimally invasive procedure that we do here in the surgery division at NewSouth.
Are you operating and seeing patients right now?
So the next question was, am I operating and seeing patients presently through these unprecedented times? And the answer is yes. We're obviously taking great precautions, and patients are in masks. I'm in a mask all day except for when I get to do a virtual visit. So in office visits where everyone's masked and we screen patients at the door. So we've still been seeing patients, but when we can and when it works for the patient, we've either seen them in a telemedicine setting, sitting right here or working on my computer, and seeing them in a virtual environment using any number of different video conferencing platforms. Or sometimes we have just delayed their appointment. Some people have questions about back pain that's been bothering them for 10 years or 15 years. And some of those people, when we talk to them, we say it might be better for us to visit after this curve has flattened, hopefully, or started to decline. And so we have delayed some folks, but usually if people are hurting, we'll see them with all necessary precautions. And oftentimes we'll start the evaluation in a telemedicine setting so that they can do it from the comfort of their home. Let me see, I don't see any other questions.
Have you had any telemedicine visits who need surgery?
Yes, so the question was, have we had telemedicine visits that need surgery? And so I should probably back up and talk a little bit about telemedicine. So in a telemedicine setting, you can do two things. There are really three, like we talked about. There are three sort of pillars to how we decide what treatment is best for a patient. Again, I talked about how we decide about surgery, and I think, again, the first part of that is there a structural problem that warrants consideration of surgery? If there's not a structural problem, then surgery is just not a reasonable option, regardless of any of the other findings. But if we think about the general evaluation of a patient, there are sort of three main pillars to that evaluation, and it's the history, which is the physician and the patient talking about what's bothering the patient and really trying to figure out when it started, how bad it is, where it is on their body. So is it on the front of the thigh, the side of the thigh, the back of the thigh, the top of the foot, the bottom of the foot? Those things all matter to me in trying to figure out what is the diagnosis. So there's first is the history, sort of what's bothering you, how much is it bothering you, and where does it bother you. The second thing is the physical exam, which is the surgeon actually putting his hands on you and testing your muscle strength, your sensation, your reflexes. Those are the main things that constitute the physical exam in my specialty. But that's the second pillar, is the physical exam. So there's the history, there's the talking, there's the physical exam, and then there's the review of imaging, which is looking at your MRI. In my practice, that's primarily a cervical MRI or a lumbar MRI and associated x-rays, and trying to see if there's a structural problem there that can be fixed and that matches the patient's symptoms. So in a telemedicine setting, we can do two of the three of those very well. So you can take a very good history and have a good in-depth, informative interaction with the patient in a telemedicine visit, and you can review their films, because you can often on the software platforms like Zoom or WebEx or any of the others, you can share screens and I can review the patient's films with them in real time, and they can see where I'm pointing and they can hear me describing their films to them.
So how do you make a telemedicine? Lauren wants to know how you
make a
telemedicine appointment.
So you can contact our office and make a telemedicine visit, or you can go online to our website, ns2.md, and you'll be directed there as to how to make an online appointment. And we have chosen the gift card winners. So the gift card winners are Tana Duckworth, a name I recognize, and James Swanner. I think I'm pronouncing that correctly. So you are the gift card winners, and we appreciate you joining us and congratulate you on winning. But yeah, so to make a telemedicine appointment, you can contact us by phone or go on the website. And even though it's a little limited, we still can do some degree of a physical exam. But for me, a telemedicine visit is really a way to meet each other and begin the evaluation process. But it's not how you would decide, make definitive choices about surgery. Thank you, everyone. I really appreciate you taking the time, and please holler at us if we can help, and everyone stay safe and well during these unprecedented times. Thank you again.